Sepsis-associated acute kidney injury, clinical integration of NGAL and Cystatin C biomarkers. Sepsis-associated acute kidney injury, SAAKI, affects is almost equal to 45% of patients admitted to intensive care units worldwide, contributing to a 30-day mortality of is almost equal to 58% versus is almost equal to 30% in septic patients without AKI. Early tubular injury releases neutrophil gelatinase-associated lipocalin, NGAL, and cystatin C, which rise within 2 hours of insult and predict AKI with sensitivities of 85% and 78% respectively. Diagnosis hinges on KDIGO criteria combined with plasma NGAL greater than 150 nanograms per milliliter or urine NGAL greater than 200 nanograms per milliliter, and cystatin C greater than 1.2 milligrams per liter, prompting rapid fluid resuscitation, norepinephrine titration to a MAP greater than or equal to 65 millimeters of mercury, and avoidance of nephrotoxins. Management integrates Surviving Sepsis Campaign recommendations, KDIGO-guided renal protective strategies, and, when indicated, continuous renal replacement therapy, CRRT, with dose 20 to 25 ml/kg/h. Key points. Note: sepsis-associated AKI occurs in 45% of septic ICU admissions and raises 30-day mortality to 58%, versus 30% without AKI. KDIGO AKI is defined by serum creatinine rise greater than or equal to 0.3 mg per deciliter within 48 H or greater than or equal to 1.5 times baseline within 7 days, or urine output less than 0.5 milliliters per kilogram per hour 4-6 H. Plasma NGAL greater than 150 nanograms per milliliter yields a sensitivity of 85% and specificity of 80% for AKI within 6 H of sepsis onset. Urine NGAL greater than 200 nanograms per milliliter provides a sensitivity of 82% and specificity of 78% for stage 2-3 AKI. Cystatin C greater than 1.2 milligrams per liter predicts AKI with sensitivity 78%, specificity 82%, and precedes creatinine rise by is almost equal to 12 H. Initial fluid resuscitation with balanced crystalloids at 30 milliliters per kilogram over the first 3 H reduces AKI incidence by 12%, RR 0.88. Norepinephrine titrated to a MAP greater than or equal to 65 millimeters of mercury at 0.05 to 0.5 g/kg/min is associated with a 15% lower risk of renal replacement therapy, RRT, versus dopamine. Early furosemide stress test, 40 mg 4, predicts progression to RRT with an AUC of 0.78. A urine output less than 200 milliliters in 2H after dose signals high risk. CRRT prescribed at 20 to 25 ml/kg/h effluent flow improves 90-day renal recovery from 38% to 55%, p equals 0.03. The Surviving Sepsis Campaign, 2021, recommends broad-spectrum antibiotics within 1H of sepsis recognition. Ceftriaxone 2G4Q24H plus vancomycin 15 mg per kilogram 4Q12H achieves adequate coverage in greater than or equal to 92% of isolates. In patients with baseline eGFR less than 30 ml/min/1.73 square meter, dose-adjusted vancomycin, target trough 1015 g/ml, reduces nephrotoxicity incidence from 18% to 9%. Post-discharge monitoring of serum creatinine and cystatin C at 3 months and 12 months identifies chronic kidney disease progression in 22% of survivors. Overview and epidemiology. Sepsis-associated acute kidney injury, SAAKI, is defined as an abrupt decline in renal function occurring in the context of sepsis, meeting KDIGO criteria, ICD-10 code N17.9. Globally, sepsis affects an estimated 49 million individuals annually. Of these, 22 million, is almost equal to 45%, develop AKI, representing the largest single contributor to AKI worldwide. Kidney disease, improving global outcomes, 2022. In North America, Incidence ranges from 38% in community hospitals to 52% in tertiary referral centers, while in Europe it averages 44%, EuroECU, 2021. Age distribution shows a steep rise after age 60, with a prevalence of 57% in patients greater than or equal to 70 years versus 31% in those less than 50 years. Male sex carries a relative risk, RR, of 1.12 compared with females, and African American ethnicity confers an RR of 1.27 for SAAKI after adjusting for comorbidities. Economically, SAAKI adds an average of $24,000 per hospitalization in the United States, 2020 CMS data, translating to an annual national burden of is almost equal to $24 billion. Modifiable risk factors include exposure to nephrotoxic antibiotics, RR 1.8 for aminoglycosides, hyperglycemia greater than 180 mg per deciliter, RR 1.5, and positive fluid balance 2L on day 1, RR 1.4. Non-modifiable factors comprise pre-existing chronic kidney disease, CKD, RR 2.3, diabetes mellitus, RR 1.8, and chronic liver disease, RR 1.5. The cumulative one-year mortality for survivors of SAAKI is 38%, compared with 22% for sepsis without AKI, underscoring the prognostic weight of renal involvement. Pathophysiology. SAAKI arises from a convergence of hemodynamic, inflammatory, and cellular injury pathways. Early sepsis triggers systemic vasodilation mediated by nitric oxide, NO, synthase upregulation, reducing renal perfusion pressure despite preserved cardiac output. Endothelial glycocalyx degradation, measured by plasma syndican 1 greater than 150 nanograms per milliliter, leads to capillary leak and interstitial edema, further compromising tubular oxygen diffusion. Concurrently, pathogen-associated molecular patterns, PAMPs, activate toll-like receptor 4, TLR4, on tubular epithelial cells, initiating NF-kappa B signaling and cytokine release, IL-6 greater than 100 pg/ml in 68% of SAAKI patients. Mitochondrial dysfunction follows, with a 30% reduction in renal cortical ATP within 6H, precipitating tubular cell apoptosis. NGAL, a 25-kDa lipocalin, is released from injured distal tubules and neutrophils. Plasma concentrations rise from a baseline median of 30 nanograms per milliliter to greater than 150 nanograms per milliliter within 2H of insult. Cystatin C, a 13-kDa cysteine protease inhibitor freely filtered at the glomerulus, accumulates when glomerular filtration declines, with serum levels increasing from 0.8 mg per liter to greater than 1.2 mg per liter within 4H. Genetic polymorphisms in the LCN2 gene, encoding NGAL, modulate expression. The RS22396708A genotype is associated with a 1.4-fold higher NGAL surge and a 22% increased odds of stage 3 AKI. Clinical presentation. The classic SAAKI phenotype presents with oliguria, urine output less than 0.5 milliliters per kilogram per hour, in 68% of cases, accompanied by rising serum creatinine in 62%. Other frequent findings include hypotension, MAP less than 65 millimeters of mercury, in 71%, and altered mental status, Glasgow Coma Scale less than 13, in 45%. Fever, greater than 38.3 degrees Celsius, is observed in 53%, while leukocytosis, 12 times 10/L, occurs in 59%. In elderly patients, greater than 70 Y, the presentation may be silent, with only subtle fluid overload, weight gain greater than 2 kilograms, and confusion, occurring in 34% of this subgroup. Diabetics often exhibit normoglycemic sepsis but develop AKI without overt oliguria in 22%, reflecting early tubular injury detectable only by biomarkers. Physical examination reveals peripheral edema in 48%, and a bedside ultrasound may show a renal resistive index greater than 0.8 in 57%, yielding a specificity of 84% for AKI. Red flag signs mandating immediate escalation include refractory hypotension despite norepinephrine greater than 0.5 g/kg/min, serum lactate greater than 4 millimoles per liter, and a rapid rise in NGAL greater than 300 nanograms per milliliter over 2H, indicative of impending stage 3 AKI. No validated severity scoring exists solely for SAAKI, but the combination of SOFA greater than or equal to 8, NGAL greater than 200 nanograms per milliliter, and cystatin C greater than 1.5 milligrams per liter predicts a 90-day mortality of 71%, or OC 0.84. Diagnosis. A stepwise algorithm integrates clinical, laboratory, and biomarker data. 1. Sepsis confirmation, suspected infection plus QSOFA greater than or equal to 2, SBP less than or equal to 100 mm of mercury, RR greater than or equal to 22, altered mentation. 2. KDIGO AKI staging, key points, stage 1, serum creatinine 0.3 mg per deciliter or 1.5-1.9 times baseline. Urine output less than 0.5 milliliters per kilogram per hour for 612H, stage 2, creatinine 2.0-2.9 times baseline. Urine output less than 0.5 milliliters per kilogram per hour for greater than or equal to 12H, stage 3. Creatinine greater than or equal to 3.0 times baseline or greater than or equal to 4.0 milligrams per deciliter. Or urine output less than 0.3 milliliters per kilogram per hour for greater than or equal to 24H. Or anuria greater than or equal to 12H, plasma NGAL, greater than 150 nanograms per milliliter. Sensitivity 85%, specificity 80%. Management and treatment. Key points: airway and breathing. Intubate if PaO2/FiO2 less than 150 mm of mercury or GCS8. Circulation. Initiate balanced crystalloid bolus 30 ml per kilogram over the first 3H, e.g., lactated ringers. Reassess MAP. If MAP less than 65 mm of mercury after 30 ml per kilogram, start norepinephrine infusion at 0.05 g/kg/min, titrating up to 0.5 g/kg/min to achieve MAP greater than or equal to 65 mm of mercury. Avoid dopamine 5 g/kg/min per 2021 Surviving Sepsis Campaign, SSC, due to higher. References. 1. Canoditis D. et al. Sepsis-associated acute kidney injury, where are we now? Medicina, Kaunas, Lithuania. 2024, 63. PMID, 3854160, https://pubmed.ncbi.nlm.nih.gov/3854160. DOI 10.3390/Medicina 600304434. 2. Weiss SL et al. Time course of kidney injury biomarkers in children with septic shock, nested cohort study within the pragmatic pediatric trial of balanced versus normal saline fluid in sepsis trial. Pediatric Critical Care Medicine, a journal of the Society of Critical Care Medicine and the World Federation of Pediatric Intensive and Critical Care Societies. 2025, 26, 6E816E826. PMID 401722287, https://pubmed.ncbi.nlm.nih.gov/401722287. DOI 10.1097/PCC.0000000000037737. 3. Nikili A. et al. Burn-induced acute kidney injury to Lane Road, from molecular to clinical aspects. International Journal of Molecular Sciences. 2022, 23, 15. PMID 359555846, https://pubmed.ncbi.nlm.nih.gov/359555846. DOI 10.3390/IJMS 231587112. 4. Spect JW et al. Effect of ibuprofen on markers of acute kidney injury, intestinal injury, and endotoxemia after running in the heat. Medicine and Science in Sports and Exercise. 2025, 57, 61092-1102. PMID 398760077. https://pubmed.ncbi.nlm.nih.gov/398760077. doi 10.1249/Mrs.000000000003659. 5. Romero Pajaro BJ et al. Biomarker-based diagnosis and risk stratification in sepsis-associated acute kidney injury, from molecular mechanisms to multi-marker panels. Diagnostics, Basel, Switzerland. 2026, 16-9. PMID 421219666. https://pubmed.ncbi.nlm.nih.gov/421219666. DOI 10.3390/diagnostics 16091262. 6. K et al. Persistent acute kidney injury biomarkers, a systematic review and meta-analysis. Clinica Chimica Acta, International Journal of Clinical Chemistry. 2025, 564:119907. PMID 3912727. https://pubmed.ncbi.nlm.nih.gov/3912727. DOI 10.1016/J.CCA.2024.119907. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.